5 things. So what's number 1? Transduction. Where does that happen? At the site of injury. Okay. Then it's conducted into the spinal cord. Into the spinal cord, it has to move into the CNS. What's that word? Neurotransmission. Okay. Then it goes up to the brain. The brain perceives that pain. The brain then sends a response to move that hand off the stove, and it also does what? Modulation, right? So now we're going back down to the spinal cord and we're saying, hey, spinal cord, you're fine. Okay, when we have this neurotransmission, don't worry about it. Don't listen to them. Okay, we're modulating what that pain signal is doing in that ascending pathway through a descending process. The WHO analgesic ladder is since I can't talk today as well, guys. I'm sorry. This is a rough day. Systematic approach for managing what type of pain? Cancer-related pain based solely on severity. Good. All right, true or false? Select herbals and supplements have FDA-approved indications for painful conditions such as OA, diabetic peripheral neuropathy, migraines, etc. False. Why? Not FDA-approved. Good. Select herbals and supplements carry risks such as increased bleeding risk, hepatotoxicity, or opioid overdose. True. What's an example of something that has bleeding risk?
Fish oil.
Fish oil. What else? Turmeric. Glucosamine, or 5Gs, right? Wintergreen. How about hepatotoxicity among our herbals? Turmeric. Kratom. Yep. How about opioids? Kratom. Yep. All right. Topicals. Either up, down, or stays the same. Okay, so systemic absorption from a topical will be increased if there is what to the skin integrity? Decreased skin integrity, right? You have a cut, a lesion. How about skin hydration? Increase. So the more hydrated your skin, if you put lotion on and then you put on your lidocaine patch, you could get more absorption. And then how about blood flow? Increased. So the more blood flow to the area, the more likely it's going to get into that bloodstream, get into systemic concentrations. All right. Topicals that have net warming effects. What things feel warm when you put them on? Capsaicin? Camphor. Okay. Lidocaine patches should not exceed 3 patches, 12 hours. All right. Increasing COX inhibition of which COX enzyme will increase your risk of cardiovascular risk? COX-2s. How about GI bleeding risk? 1s. Okay. Does increased cardiovascular risk and GI bleeding apply to all NSAIDs? Yes. So regardless of their COX selectivity, they all carry those risks. Anti-inflammatory effects are going to occur at what types of doses of NSAIDs? High intensity NSAIDs. Good. Salicylate toxicity, or aspirin, is going to involve respiratory alkalosis and metabolic acidosis. How do we treat that? Bicarb? Charcoal? Supportive care? Worst case scenario, hook them up? Dialysis. Okay. So not all medications can come off with dialysis, so aspirin is one that can. Questions on our memory jogs? All right, we have more abbreviations. Our objectives are in the syllabus. Agenda today, so we're going to talk about our remaining non-opioids. Talking about acetaminophen or APAP. Brand name is Tylenol. I'll probably use that interchangeably just out of habit. I do not endorse it as a branded product. Antidepressants, anticonvulsants, skeletal muscle relaxants or SMRs, and then a few other things that you guys may see. We'll wrap it up, and then additional resources. Depending on time, I would like to start the opioid piece just so you have that info going into your gout and OA lectures when it is discussed. So we may touch into part 3 today. So again, looking at our map, these are the ones that we'll be covering today and some of the nuances and classifications within those. Starting off with acetaminophen. Some fun facts. So it's APAP. Its abbreviated nickname is from its chemical name. It came to the market in the 50s. However, it really wasn't accepted until the 70s. There's another medication that metabolizes into acetaminophen, and that medication had some really bad side effects with it. Has anyone heard of the Chicago Tylenol murders? Yeah, some crime scene scenes. So essentially in Chicago, someone, don't know who, went to different supermarkets, opened up Tylenol bottles, put in cyanide, closed them up, put them back on the shelf. You go home, you have a little powder in your thing, you're not going to think of it, right? There's just pills in here. You take your dose, what happens? Dead. Okay? So a lot of people ended up dying. They find out that it's a cyanide issue, and they end up finding receipts from a few of these people indicating that they just bought Tylenol. It was from this site. And so this led to having those safety seals. So we didn't have safety seals before this. So those nasty little metal papery things that are on top of all of our bottles are because of these murders. So likely many more happened, but 7 were only the ones that were confirmed due to this concern. So you may have older patients who may remember these and think that Tylenol is the worst thing because of these murders. Giving that information and insight can be helpful. So how acetaminophen works, it's going to be an indirect inhibition of prostaglandins. Okay, indirectly it's inhibiting those. It's primarily doing that within the CNS. Okay, NSAIDs are going to be in the periphery where we're doing that action, right? Acetaminophen, we're doing that in the CNS. Meaning our net effects when we use acetaminophen are going to be our central effects. So we're not going to be seeing that anti-inflammatory benefit that we see with NSAIDs when they're working in the periphery. We're mainly just seeing that pain perception, and we're also seeing that fever reduction. Uses are going to be similar. So our mild to moderate non-inflammatory pain, right? We're not getting into the periphery to help with that inflammation. Self-limited painful conditions. So again, we're just changing that perception of the pain that's helping with that self-limited condition. And then any sort of pain or fever effects during any illness. Comes in tons of different preparations. So acetaminophen is the other one that does have dosing limits that I expect you guys to know. So maximum dose is going to be 4 grams if someone's monitoring it. Okay, if you are monitoring all their labs that we care about when talking about acetaminophen, 4 grams is the max. If they're getting it over the counter, or if you don't want to monitor their labs, the max is 3 grams. Typically, I don't like to monitor people's labs. So I typically tell most of my patients 3 grams. They've done studies looking at just average population, and roughly 5% of the population is taking an average of 5.2 grams a day. So keep that in mind when you're recommending these things to patients, that right in a typical week, you're probably going to see patients that are taking exceedingly high doses of acetaminophen. If they have hepatic concerns, they can still use acetaminophen, but now we are capped at 2 grams. For our peds, didn't do my transitions. For our peds, our dosing is 5 to 10, Q4 to 6. Remembering that ibuprofen of our NSAIDs, or Motrin, or Advil, same thing, has this other peds dosing. What is the commonality between both of them? 10 mg per kg per dose, Q6 hours. Okay? So really it's just memorizing one dose. Okay? One you can fudge a little bit north, one you can fudge a little bit south. Okay? So, starting the day off strong with little Miss Charlotte. She has an ear infection, and she was advised to take some Tylenol to manage the pain and fever for a few days, along with a course of antibiotics. Right? I know that's really controversial. I don't know if you guys have gotten there yet. Really controversial, right? So again, we can take her age, we can take her weight. Okay, she's 12 kilos. What dose did we say? 10 mg per kg per dose. Throw a 0 on that. Okay. How often can she take it? Q4 to 6 hours. Yep. Q6 is the one that's in between. Hypothetically, if we had to transition that to a solution, we could then take the concentration of a solution. Okay. If it's a 100 milligram per 5 ml or something like that, we could do that math. Because I'm pretty sure on your exams you have 2 mandatory math questions. Maybe. For reading? Okay, good, good. All right, the duration of benefit is that same dosing interval, so 4 to 6 hours. Side effects, GI upset is really mild. Take it with food. Headaches, itching, and rash can sometimes happen as well with it. Rarely do I see it commonly within my patients. A big drug interaction is going to be warfarin. A big food interaction is going to be alcohol. Okay, both of those things require the liver, and that is our box warning, hepatotoxicity. Okay, that's our biggest issue when talking about acetaminophen. NSAIDs, we had all these other issues, right? We spent 30 plus minutes talking about all these issues with NSAIDs. Acetaminophen it hurts your liver. Okay? Meaning, acetaminophen is going to be our preferred choice in patients that have cardiovascular issues, renal issues, GI bleeding, and pregnancy when we compare it to our NSAIDs. Okay, so those are patient populations where we're going to pick acetaminophen for just a general fever or a mild ache and pain. We're going to pick acetaminophen over an NSAID. Yeah.
Could you take it in lieu of aspirin?
So can we take acetaminophen instead of aspirin, assuming that they're taking aspirin, or in lieu of aspirin? They're taking a low-dose aspirin for cardiovascular. Can we also take acetaminophen?
Could you use it instead?
Gotcha. Can we use it instead? So mechanistically, aspirin or acetaminophen is mainly going to be working in the CNS, meaning it's not going to get into the periphery to help with those platelets. So that's the downside, where NSAIDs will be in the periphery, they'll bind to those platelets. So we do still need to work with our NSAIDs to get that bleeding benefit, that cardiovascular benefit. Good question. It's another good reminder, what's the benefit of aspirin versus our other NSAIDs? Why do we use aspirin as our cardioprotective? What's its mechanism difference? Irreversible, right? You guys are going to be thinking, like, what were all the silly things that Nicole was doing all lecture, right? Aspirin is going to be irreversible. It's binding to those platelets. It's keeping that platelet inactive for the duration of its life. Other NSAIDs hold on to the platelet and then let go. Acetaminophen doesn't even see the platelets. Okay, it's just in the CNS. Good question. Other questions? When thinking about how acetaminophen is metabolized, part of it, so 5% will be just renally excreted unchanged. The majority of it is going to go through the hepatic conjugation through glucuronidation. We can get some sulfa component as well. 10% is going to turn into NAPG. NAPG has cellular toxicity. Okay, I think we're good. NAPG goes through the P450 pathway. NAPG has cellular toxicity and hepatic damage. Okay, so we are hurting the liver cells with this metabolite. You can imagine in excess, with higher dosing, we're going to have more of this metabolite form, and more of the liver is going to be damaged. Okay? NAPG naturally is going to be cleared in the liver. I take a dose of acetaminophen, I get this toxic metabolite, my body then will metabolize it again to a non-toxic metabolite. We naturally are going to do that. Okay? Unfortunately, that pathway, so using glutathione to make it non-toxic, can be depleted. Whether that's with aging, we may not have that process as well. We may have different environmental toxins, stressors. We could be malnourished. We could be drinking a lot of alcohol, which is going to deplete that pathway, or we could have really high doses. Any of those things are going to result in NAPQ not being metabolized further. Okay? Is NAPQ good or bad? Bad. Okay, we don't want NAPQ. Some things that you may see, so whenever we're worried about some sort of toxicity, we always want to call our lovely Poison Control Center. But when we're thinking about the toxicity with NAPQ, we need to determine, is this person at risk of having a hepatic injury that is so significant it could be fatal or require transplant? Okay? What we do is after 4 hours, we draw a Tylenol or an acetaminophen level from their blood. We wait 4 hours because that's the amount of time it takes to fully absorb that dose. Okay. After 4 hours, we now start to plot where this concentration is of acetaminophen. If it's above the line, you give them treatment. If it's below the line, we're not worried. Okay. Above the line, we're concerned. We're at risk of having hepatic damage, irreversible hepatic damage, and we need to do something about it. Below the line, we're fine. The treatment that we use when it's above the line is N-acetylcysteine, also known as NAC. We can also use activated charcoal in acetaminophen overdoses. What else can we use activated charcoal for? That we've talked about? Aspirin, good. Activated charcoal is only going to be good if it's less than that 4-hour window. Typically, it needs to be less than 2 hours, ideally, but for sure less than 4 hours since ingestion. We're going to give NAC whenever it's above that line, or when they have really high other risk factors. So they have an ingestion, a single ingestion of 7.5 grams. If we don't know when they took it, and their Tylenol, their blood concentration is high, they get treatment. If they have any acetaminophen use and any evidence of liver injury, they get treatment. Or if they have a delayed presentation. Hey, I took this whole bottle of acetaminophen. I didn't want to tell my command, but I feel riddled with it. It happened 2 days ago. We start them on treatment. What is NAC? So NAC is going to replenish that glutathione pathway. So it's just a replacement. It's going to say, hey, body, do your thing. Here's some glutathione concentration for you. We're going to increase that supply. That NAPQ is then going to be metabolized and conjugated to a safe metabolite, and then we're going to reduce that toxicity risk. There's 2 different routes that we can do. So we can do orally. This is through Mucomist. It's an inhaled product. We rarely use it. It smells horrible. It smells like rotten eggs, horrible sulfurish stuff, not enjoyable. How you do it, because of its poor taste and smell, you are at more risk for throwing it up. What happens if you throw it up? You get to do it again, okay? That's not very ethical, in my opinion, to make someone suffer through that, right? So IV is typically the preferred route that we're going to use. We have either a 20-hour or a 21-hour method, either using 2 bags or 3 bags, and then we do that based on what your institution wants to do, what poison control advises you to do. They're similar. There's been many other studies suggesting maybe doing shorter infusions to reduce length of stay or other things, but 20 to 21 hours is fairly standard for doing an IV treatment, meaning these folks are going to be admitted for at least a day. we meet Kyle. Kyle presents to the ER 6 hours after ingesting 30 tablets of acetaminophen. He complains of extensive GI upset and depressed mood and motivation related to numerous life stressors. So what do we do? So too late for charcoal, good.
Pump his stomach.
Okay, we're gonna get a lab. So how much did this person ingest? A lot. Okay? Do we have to get a lab? So what were the criteria that said we're going to start it if it's above the line if we get a lab? What were some of those other things? So if it's above 7.5, we're above that, right? You take a large ingestion, we're really concerned you're going to have hepatic damage, we're going to start NAC. We can still get a lab, we can still plot it, but we're not going to delay treatment to wait for that lab to come back. Does it change if he also tells us, well, I drink a whole bottle of alcohol and all these things, Abbott's just been drinking this whole time? Potentially also changes, right? History of hepatic damage. All those things are also going to be part of that. All right, so clinical pearls with acetaminophen. We have pain perception, analgesic, and antipyretic effects because we're inhibiting those prostaglandins indirectly in the CNS. Dosing acetaminophen should depend on how closely we're monitoring for the risk of hepatotoxicity, and we need to make sure that we're not exceeding certain thresholds. Acetaminophen is well tolerated and preferred in select patient populations compared to NSAIDs. And then NAP will replenish glutathione stores and deplete accumulation of NAPG, and that's that hepatotoxic metabolite. Questions on acetaminophen?
The select pair settings, that just refer to like IV?
So that's more so, right, are you monitoring it, and are they in clinic or in the hospital? Are you getting liver labs? Then you can go up to that 4 grams a day, right? If you're not monitoring it, they're just coming to clinic, you don't want to draw labs, you're out in the field, you don't want to draw labs, 3 grams a day.
Would IV Tylenol change the parameters of ultimate blood draw per deciliter? Would that change it? Does it go straight to the blood versus first pass?
So still same concern, yeah. So question being, does it matter if it was either oral or IV Tylenol where those thresholds are? No change. Okay. Other questions? All right, so up until this point, most of the meds that we've talked about have treated what types of pain? Nociceptive, somatic pain, okay? A lot of these ones moving forward are going to touch a little bit on that, but more so some of our neuropathic pain conditions, okay? So starting with antidepressants. Antidepressants, the main 2 classes that we're going to be using are SNRIs and our TCAs. You guys have already been taught on all of these lovely things in your psych lectures, so I don't need to go super in depth with these. Remembering that pathophys, so we have serotonin and norepinephrine are going to be inhibitory neurotransmitters in that pain pathway modulation. Okay, our brain said, oh my gosh, we have pain. Hey, come back down to the spinal cord and stop these 2 from yapping. Okay, the periphery is saying I have pain, this other thing saying I have pain. You put a little stop between that. So serotonin and norepinephrine are going to do that mechanism, change that modulation from a descending standpoint to change that ascending signaling. We're modulating that pathway. Primarily, antidepressants are going to be for chronic pain. It's going to take roughly 4 to 6 weeks for them to really start working. Talking about SNRIs first. So mechanistically, we're doing presynaptic reuptake inhibition of serotonin and norepinephrine within the CNS. We're going to use these both for nociceptive and neuropathic. Chronic pain conditions can be musculoskeletal, neuropathic, fibromyalgia are pretty common for these ones. Side effects are going to depend on their another mechanism. Okay, so serotonin, we have things like sexual dysfunction, GI upset. Norepinephrine, they're more activated. Okay, so thinking about those different things are really going to give us our side effect profile. Because we have serotonin, we also need to be mindful of serotonin syndrome, which we will circle back to at the end of this piece here. Hypertension, why would someone potentially get hypertension with an SNRI? Yeah, so we have norepinephrine, but also if they do develop serotonin syndrome, we can see hypertension with that. But the norepinephrine component, right? If you just take a shot of norepi, your blood pressure is going to be loving it. The three main ones that we'll discuss, milnacipran or Savella. This is the most norepi among our different agents, meaning it has the most risk or highest risk for that hypertension. Its only labeled indication by the FDA is for fibromyalgia. So even though it's an SNRI, it has no mood, no anxiety indications, solely fibromyalgia. The next one, venlafaxine or Effexor, has moderate norepi. It is dose related, so the higher the dose, the more risk for that hypertension risk that can happen. It has no FDA approved pain indications, but we use it off label for many different things. A lot of the initial studies for SNRIs were done with venlafaxine. Our preference is usually duloxetine. It has the least amount of these of norepi, meaning it's better tolerated from a blood pressure standpoint. It is, however, a 2D6 inhibitor. Okay, so what's that potentially going to mean for us? You have to be mindful of drug interactions. Okay? It has a ton of labeled indications. So fibromyalgia, chronic musculoskeletal pain, neuropathic pain associated with diabetes, the list goes on. Duloxetine in recent guidelines has been one of those, along with NSAIDs, that are typically a week 4 recommendation. Okay, not a strong 4, not against, but typically a week 4. There's good data to support its use. Again, because we're targeting a unique pathway, that modulation. Questions with SNRIs? Moving to our TCAs, we're going to have both the same mechanisms with that serotonin and norepinephrine, but now we also add in some of these more dirtier mechanisms. So now we have anticholinergic activity, we have histaminergic activity, we have alpha-1 activity. Okay, we're antagonizing there. While we could use these for nociceptive, mainly we're going to use these for neuropathic. We can also use these in fibromyalgia. Side effects? Lots. Right? This is going back to the fact that it has all these different mechanisms. So again, when we have serotonin, GI upset, sexual dysfunction, serotonin syndrome, norepi, right? Is it more activating? All these other things. Anticholinergic, we're drying out. Histamine, now we're sedated. Okay, and alpha-1, are we having blood pressure imbalances? We need to be really careful when using our TCAs in a variety of patient populations, right? So because of those mechanisms, we're probably not going to give it to our elderly, frail person who's at risk of falling, right? We're probably not going to give it to someone who has a lot of renal and hepatic injury. So think about some of these different things. Seizures is another one that TCAs can be concerning for as well. TCAs are contraindicated in anyone who's had a recent MI. Overdose is fatal due to cardiac arrhythmias or dysrhythmias. So you're not going to give it to a patient who is expressing that they have SI, suicidality, who have risk-taking behaviors, or if they have memory impairment. If they don't know if they took their dose and they're just going to take another one, and then 30 minutes later they don't remember if they took their dose and they take another one, that's not going to be safe for the patient. The three agents that we'll focus on here are going to be amitriptyline or Elavil, doxepin, which we can have a compounded formulation for topical, and then nortriptyline or Pamelor. Amitriptyline and doxepin are tertiary, meaning they're a little bit more dirtier of the TCAs. Nortriptyline is a secondary amine. It's going to be a little bit more cleaner side effect profile-wise. Amitriptyline metabolizes into nortriptyline. Amitriptyline has more serotonin syndrome or serotonin effects in it. Nortriptyline has more norepi effects in it. Doxepin, while we do have an oral formulation, it is not indicated for different pain conditions. Only for some of our mood conditions, insomnia, and then if kiddos are having issues wetting the bed or different things, we can use it for that, for its anticholinergic properties. The topical formulation is used off-label for neuropathic pain. Sadly, whenever we use it, we see that systemic concentrations are equal to that of taking the oral. So while we think it's going to work topically, it seems to be more of a transdermal, that it's still getting into systemic concentration. Compounded, it's still fairly expensive, so over $300+. Questions on our TCAs? All right, serotonin syndrome happens from an increase in the amount of serotonin. It's going to be very sudden, typically within 24 hours, typically within hours of that increase. It's usually compounded whenever we are also taking one more thing that could have serotonin in it. Whether we increase the dose of our antidepressant, whether we add on some of our migraine medications that are as needed have serotonin. And so if you're having a migraine, you're taking your antidepressants at that time, now you have a migraine, you take your migraine med at the same time, you're taking some pain meds that also have serotonin that we'll get to. That can really compound those effects. Okay? I've seen it about 3 times. Has anyone seen serotonin syndrome? No. Okay. So every time I've seen it, I was in the ER. Patients come in, they look incredibly uncomfortable. They cannot sit, they cannot do anything, they want to get out of their skin, is the best way I can explain it. There's no way to rationalize with them, like, sit down, you're fine, like, I'm just going to take your blood pressure. No. They are jumpy, they are doing all these things. So when I counsel my patients, I always say there's 3 things, and I turn into a flight attendant. I say your mind is going to be really confused. You're not going to know what's going on. You're going to be foggy. Things aren't going to make a lot of sense. Your body, you're going to have a fast heart rate. All these other symptoms are going to happen. Your tummy is going to hurt. You're going to be sweating. And then your muscles are going to start shaking. You're going to get a tremor. Okay? So I really do mind, body, muscle. And I counsel my patients when I do that. If you notice those things, don't ignore it. Right? Don't think that you just got the stomach bug or you have a flu all of a sudden. If those things line up and the stars are aligning, what do we do for them? How do we treat serotonin syndrome? So it can try some things, but there's really not a standardized, this will work every time. Okay? So there's some things that we can help with the tremors, but we can't do anything about the serotonin issue. That piece needs to run its course. So we're going to stop the things that are causing it. We don't want to keep making it worse. We can give fluids. Again, we can stop those tremors and different things that are going on in the muscles. We can try to manage that as best we can. But it's really going to be a lot of cooling efforts. There's some serotonin antagonism that we can use as well. Questions on serotonin syndrome? Scott returns.
Oh boy. It's a cold ranger.
All right, remember, chronic axial low back pain. Had imaging, he has appropriate changes that are going on, nothing scary. He doesn't like to really be motivated to do his exercises. He hasn't previously been interested in meds because he wants to toughen it out. Would he be a candidate for antidepressants? Maybe. Okay, which ones might we consider? TCAs or SNRIs? SNRIs, why not TCAs? more problems, more neuropathic pain, right? He's just got axial pain. Okay, so he's in that somatic boat. So we don't need to get the TCAs involved. Okay? We could explore, does he have some mood concerns? Right? Seems like you're not really feeling that motivation. Tell me a little bit more about that. Okay? You previously haven't been someone who wants to take something every single day. Do you think an antidepressant is going to be a good option for someone who doesn't like to take something every single day? No. Okay, so that's typically my biggest barrier with patients. If you just like to take something when you feel you have pain, we're not going to do an antidepressant for you. Okay. Again, this is something that you're going to get buy-in for. You're not going to see these changes for about another month or two. You've got to stick with it. Okay. Clinical pearls. SNRIs and TCAs are going to help with that modulation for chronic pain and that ascending pain signal. We have unique side effects based on these agents that is going to guide our selection for different populations. And remembering that agents that have serotonergic therapies can also result in serotonin syndrome, which could be fatal. Questions on our antidepressants? Not like so excited today, I see. You're not in uniform, most of you, so that's a positive. Maybe a little more comfy. It's not as hot as yesterday. That's a good thing. All right, we're going to do one more subsection here, and then we'll go for break. So our anticonvulsants. Again, these are going to be more of our neuropathic pain considerations. We have lots of different agents, and they're kind of classified in different things. So we have our gabapentinoids, which are gabapentin and pregabalin. We have some more of our traditional things that we think about when thinking of our anticonvulsants. Phenytoin, theoretically, and those types of things could fall into here. We rarely use them just for the side effect profile. Benzos, there's tons of different benzos that are out there. And then topiramate is kind of by itself. So mechanistically, they're going to be working on the action potentials, okay, within those neurons. So we're just changing those voltage-gated channels and doing something. Some are going to be this electrolyte, some are those. Okay, we're just changing the different atoms that are moving. These are going to be those mechanisms for each of those, just as a quick summary. And like I mentioned, these are more for those neuropathic type pains. So whether they have neuropathies, fibromyalgia, headache disorders can also be incorporated into some of our anticonvulsants. Okay, so again, just a little summary on this page. Going into each of these groups individually, so gabapentin or Neurontin or pregabalin or Lyrica are two options of gabapentinoids. Pregabalin is a controlled substance. Okay, it's a C5. What does that mean? High risk, low risk? Lower risk, good. Is it illicit? No. Right? Which ones are illicit? Ones. Okay. So these are going to work on the alpha-2 delta subunit, inhibiting calcium influx, all these things. So unfortunately, even though they're not, because they're gabapentinoids, they sadly don't work on gabapentin or on our GABA receptors. Okay? Gabapentinoids do not work on GABA. We're working on this calcium influx of this alpha-2 delta subunit. As we mentioned, more so that neuropathic pain, post-herpetic neuralgia is a common one for these. We can also use this for post-op pains. It's slowly starting to fall out of favor, I would say. I wouldn't be surprised in the next few years if it truly is not one of our standards for post-op pain. Restless leg syndrome, and then theoretically opioid sparing as well. Dosing with these agents, we're going to start low and titrate slowly, typically no sooner than every 3 to 7 days in the outpatient setting. We do need to renally dose adjust both of these agents. Side effects, drowsiness, dizziness, headache, ataxia, fatigue, nausea, edema, and weight gain. The weight gain is due to the edema, okay, so it's not a separate thing. In December of 2019, the FDA put out an alert saying that gabapentinoids maybe aren't as safe as we initially thought. We have increased risk of fatal respiratory depression in those that are on other respiratory depressants, those that have respiratory conditions, or in our elderly population. Okay, so this is not a boxed warning. It's just a statement that the FDA observed. So for this reason, this is why I personally, right, this is my viewpoint, this is why I think gabapentinoids are going to start falling out of favor. Because of this risk and this correlation that we're starting to see. Moving on to some of our typical anticonvulsants. These three agents that I've included are going to work on our presynaptic sodium channels, having that stabilization on that membrane. Again, working in more of that neuropathic pain condition. How do we remember that? Because it's working along that nerve signaling. Okay. Dosing similar, start low, go slow. We can do drug level monitoring for these agents. Drowsiness, dizziness, headache, GI upset, skin reactions, especially with lamotrigine or lamictal, skin reactions are very common and potentially not good for those patients. It is the speed at which we dose these patients, so how quickly we titrate them for lamictal. Metabolism, I have a little liver here. So it is hepatic metabolism. They are 3A4 inducers, meaning these will give us a lot of drug interactions. So if I give you a patient with a laundry list of meds, and it says, which anticonvulsant do you want to give them? Are we going to pick this one? Drug interactions galore. All right, our benzos are actually going to work at GABA. They're going to work at GABA A. So this is a chloride influx change. So benzos are classically considered anticonvulsants for their primary use, which is why they're listed here as a single slide. But we will actually circle back to them when we talk about our muscle relaxants. So these primarily will be used for muscle spasticity. We have many box warnings. So risks with concurrent opioids, risk for abuse, misuse, and addiction. These are C4s, controlled substance 4s. And then we do have risk for withdrawal, which could lead to seizures. Okay. Then our last one in our anticonvulsants is topiramate. Topiramate is fun because it has multiple different mechanisms that it's doing on this little action potential. So we're changing sodium, we're changing calcium, we're changing GABA. We're going to use it for our neuropathies, fibro, and this is one that does come in for migraines. However, interestingly, a side effect is this brain fog. Word finding difficulty is another one that comes up. I know you guys are thinking, oh, Nicole must be on this. No, Nicole just can't pronounce words. Weight loss is potentially a benefit with this one. Okay, so I have a patient that I'll be seeing that I'm anticipating I want to start topiramate on because of their weight. Okay, in the military, there's certain things that you guys kind of can't use for weight loss. So this is kind of one of those things that, you know, you got neuropathic pain, you have migraines, maybe we consider topiramate. Okay. The downside is that it is a renally excreted medication that does depend on relatively healthy renal function. Okay, so we do renal dose adjust when we're below 70, which is a relatively high creatinine clearance that we would dose adjust from. And we can actually get kidney stone development at any dose. So patients need to ensure that they're maintaining their hydration, that they're not out in the field and in the sun for 2 days and then back in a nice air-conditioned place and then somewhere else. Right? This wouldn't be a med that I want anyone to be on in a hot city for, and not a routine schedule. So we got Mr. Paul, 68-year-old. He has concern for unmanaged restless leg syndrome, preventing him from getting comfortable at night. He has a past medical history of hypertension, hyperlipidemia, prediabetes, nephrolithiasis, acid reflux, eczema, atopic dermatitis, all the things, goodness. His living situation is that he's the primary caregiver for his aging parent. He is on 20 plus meds and supplements. So let's talk through him. Let's start with pyramid. We just talked about that one. Pyramid, good, bad. What are our concerns with Paul? Kidney stones. Okay, kidney stones, potentially not great. He has a history of kidney stones, right? What came first? So maybe not great. Okay, anything else with pyramid? Potentially weight loss, right? Maybe it could be good, maybe it could be bad. He's got prediabetes, hyperlipidemia, could be beneficial. He's 68, so renal function may be questionable. Okay, going back one more, benzos. We want to give Paul some benzos? Quick no.
Yeah.
Why not?
Primary caregiver or caregiver.
Yeah, ethically, he's a primary caregiver. So benzos may not be a good thing to give someone who's a primary caregiver and is responsible for the health and well-being of someone else. Also, we don't know necessarily, does he have other muscle spasticity concerns, right? Maybe we need to explore that a little bit more. How about some of our traditional anticonvulsants? Drug interactions, yeah, so it's going to be our big limitation. He's on a bunch of supplements, and we're not going to have good data on that either. Maybe he's on some that are bleeding risks. Now we're inhibiting that metabolism, right? Don't want to touch those with a 10-foot pole type thing. Send them to neurology is always what I tell my docs. So gabapentinoid? Maybe. Okay. Again, our side effects are going to be dose related. So maybe we start with a low dose. Okay. See how it works. He is elderly. So for that new update, we are at risk for respiratory depression. He thankfully doesn't have any COPD or things like that we know of. So he's not at a prior respiratory risk. So this, I would say, is a very clinical case that I would be asked to discuss with my teams. Okay? Is this the type of case I'm going to give you for the exam? Hope not, right? We're going to make it very clear and straightforward, right? Oh my gosh, he has kidney stones. So imagine he has kidney stones, his liver is not good, all these things, right? I'm going to make it pretty clear for you, is my hope. Okay? In summary, we're mainly going to use these products for neuropathic pain conditions. We're going to start low and go slow, remembering that we have CNS depressive effects and risks, and then we do have those different categories. Questions? I do want to take 1 second. So I have one of my students who's with me on rotation. She stopped by today, so she's in the back of the room, Emily. So we will go for a break, but if you have questions for either myself or Emily, we are happy to help. If she doesn't know the answer, she can send it back up to me. She does not know what questions are on your exam, so don't try to hassle her. With that, we'll go for a break. Come back at, 32-ish?
Oh boy.
So if I want to, this is what I do. It could be after. You want this?
So probably just the makers of
He's like 3 years old. Was that a door?
You know he likes to tough it out.
Sweating off. Consistently died already. Yeah, I wasn't going there. I wasn't. No, guys, you would have went there.
I got you. How did I celebrate?
Kind of like. I don't care. Depends on what you want. Just let her pick how you remember. Typically, we go like sushi.
They got me. They littered my office with balloons. Yeah, hey man.
But I mean,
I'm trying to get out of here.
again, when I was telling you, I know the place, I don't understand, like, how to drive. Does that make sense?
So Monday for sure.
Don't go to the place. We've had bags. Like places that actually make it.
Whenever you got time.
12 hours
I eat a lot.
I don't know what they're. I have students that teach at some point. You're part of that. You're part of this. Whatever that boundary is. No, I like it. It's a cool
Your drink. Because I like to get that.
I can't call me party doing
Well,
I would love it. Yeah, makes sense.
That's my favorite. I tried both. I like
meetings is
But once that, like,
Somebody actually.
it doesn't go well. You got cold this, like, hot drink,
We're all retired eligible.
I can't say I've tried it enough. The place I've tried the hot sauce cream.
I'm going to bed.
But I really do enjoy the, like, the
I'm
very.
still trying to get my freaking connection stuff. Right? Right? Wow. Freaking go over there.
Really quite fun.
They can do things. They just keep telling me it's great. I'm trying to it takes 30 to 60 days to process. So I'm like, I just need to push the button for the other people. You're not going to find out. Just let me know which desk it's on. If I have a patient or readjust the broken bone, it's too long. So I'm trying to get right to it. I'm getting answer now. I think I got it for a week. So, I gotta go start seeing patients. 40 per year. I took 2 days to call. That's where you're like, don't even 2 days to call. The whole point is to the hospital and then to the people. So they keep bugging me saying, hey, you haven't seen the picture. I know. I'm trying to get the picture. You know how to call. Don't worry, every time you see stuff in the future, I'm sure some running around, packages on searching for you have to go to like and then empty up the
Yeah, exactly.
Surgery guy, yes, everyone in the operating room, like, what are you doing up here? You're not going to answer. He must be fixing I have a little
That's what I mean. Yeah. We're some friends, so I don't know. Yeah, and they paint over
Here we go.
questions on this part? Okay, what agents did we talk about? Methods, Tylenol. What things do we have to remember about that one?
Napkey.
Catotoxicity with NAPI. How do we treat it? Nah.
Give him a snap.
Okay. Are there dose limits?
Oh, yeah.
Oh yeah. Oh yeah. Okay. What's the peak dosing? 56. Okay. 10 to 15. Good. Then we talked about antidepressants. What two classes do we use? Good. They both have serotonin. What could happen? What are some side effects or symptoms that you might have if you have serotonin syndrome? I hope on the exam you guys are doing that and heart is just really confused. Right? Okay. All right. Then we talked about anticonvulsants. Okay. We have what's kind of the broad picture with those? Types of pain? Neuropathic. Okay. Dosing? Start low, go slow. Side effects? Pretty clean? Pretty tired? A lot of sedation, a lot of CNS. How do they work? Sodium, calcium. Okay, we're working on that action potential with our anticonvulsant. Alright, now we're going to go into our skeletal muscle relaxants. The biggest thing that we have to think about with these are what are we treating? Are we treating spasticity or are we treating spasms? Emily, I'm sure, can tell you that that is my first question that I ask my docs when they come to me. Wait, they got muscle stuff. What stuff? Right? Give me a little bit more. So, what's the difference between these two? Spasticity versus spasm.
Trick question, I would say.
Good answer.
Okay, talk with your partner. Make it make sense.
Shake the desk.
Which ones?
Alright. So someone has a Charlie horse. What are they having? Essentially spasm. Okay? If someone is born with cerebral palsy, what do they have? Spasticity. Okay? So the difference is whether it's central or peripheral. They're not trying to do any of these things. These are all involuntary. Okay? But it depends kind of on that frequency and the nature of that muscle movement. So we have all these different uses. Okay? I'm not going to go into uses on every single slide for which they need which for. It's based on that indication. Is it spasticity or spasms? So if you get a case that has a person who has cerebral palsy, you need to say, hey, cerebral palsy is in use in spasticity. What are my medications that are treated for spasticity? Okay, and that's how I'll teach them to you. Okay. We have different agents within each of these. Okay, so based on the type of muscle pattern that they have, will determine which agent we use. The agents sorted are here. So the ones on the top are CNS depressant mechanisms are for spasms. Soma, that's kind of in this light blue here, our GABA A agonist, is also a CNS depressant. It is also for spasms. Okay, but that's kind of where we start having overlap because our benzos are GABA A agonists. Diazepam is a benzo. And so those in the green then are all for spasticity. The ones for spasticity all have different mechanisms. So spasms, how they work, somehow they depress the CNS. Interestingly enough, what did we just say on the last slide? How do spasms work? They're a peripheral action. Okay. So my bias, I usually don't like treating spasms because all we're doing is telling the brain go to sleep. You're fine. Stop freaking out, even though it's a peripheral issue. Guidelines also usually don't support their use. Alright, Alright, so starting out with our spasms, cyclobenzaprine or Flexeril is going to be a CNS depressant, as we mentioned. It is structurally similar to our TCAs. So up here, I have 3 tricyclic structures, 3 cycles, tricyclics. The 2 on the outside are amitriptyline and nortriptyline. The one in the middle is cyclobenzaprine. What side effects might we expect from cyclobenzaprine? TCA type side effects. Sedation, dyspnea, weight gain, all these different things. If someone is on a TCA, should we put them on cyclobenzaprine? No. How often do I de-prescribe in my clinic that exact thing? Often. Okay. So cyclobenzaprine is in the name. Cyclobenzos. Okay. It's going to be your TCA side effect picture. We can get serotonin syndrome from this as well. Our same risks occur, right? Different arrhythmias. You're not going to give this to your patients who are forgetful or who are going to overdose with it. It can also lower that seizure threshold. Be cautious with other populations that are going to be at risk of that CNS depression. Big takeaway with cyclobenzaprine. Looks like a TCA, it acts like a TCA. Metaxalone or Sclaxin, a beautifully named muscle relaxant, is a CNS depressive. By nature, we don't know exactly how it works, but this also has serotonin syndrome risk in it. Borzoxazone or Borzone has fatal hepatotoxicity. Fatal hepatotoxicity, so not just normal hepatotoxicity, you can die from it. We rarely see both of these foods. Alright, methacarbamol. Also, we don't really know how it works, it just depresses the CNS. We can give it orally, IM, or IV. Oftentimes at AMC, we see this used post-op. Its dosing, it unfortunately has an extremely short half-life. So we have to dose it multiple times a day. It also has tachyphylaxis, meaning as we continue to take it, it's not going to be effective. So it's different than tolerance. How I like to think of it is we don't really know how it works. So I think of it that we have this unknown supply of a neurotransmitter. We take methacarbamol, it uses some of that. We take some more, it uses some of that. And our body can't keep up making that. So typically after 3 days, that supply is gone. We keep taking methacarbamol, but it's not doing that mechanism anymore. It's strictly just sedating. So you get all the side effects from it without any of the actual mechanism. So how long should methacarbamol be dose limited for? 3 days. Okay. It has unique side effects of urine discoloration. It can also have things like blurry vision, hypotensive dizziness, sedation as well. Inpatient side, right, we're using this post-op. Don't be quick to just say that someone's dehydrated and order fluids on them just because you look at their urine. Okay? Are they taking methacarbamol? Are they taking Robaxin? Cool. Right, let's check some other labs, make sure their kidneys are fine. Okay, they can change the color of their urine. Methacarbamol can also lower the seizure threshold. So again, we're going to be cautious in those that are elderly, that are on concurrent CNS concerns as well. Phenidrine or Norflex, another good brand name product, right? This is an analog of diphenhydramine, also known as Benadryl. So what is it going to act like? Benadryl. Okay, what are some side effects you might expect from it? It's going to be sedating. Okay? So again, we can see the chemical structures. Not that I expect anything beyond, well, they look alike. Right? We're going to have very similar side effects. We need to limit these to they have extensive hepatic metabolism, we can get euphoric with it, tachycardia, dry mouth, all the things that we would expect with Benadryl. We're gonna avoid it in our elderly population. Lots of different contraindications with it. Our last agent for spasms is gonna be, never say this one, as you guys probably already know by now, Crisopronol, Soma is the brand name. This one is controlled. So this is our only one for spasms that is controlled. CNS suppressive, and we have GABA A agonism. We have a metabolite that is a barbiturate-like. What do we know about barbiturates?
Bad.
Love them, hate them?
Bad.
Don't love them, kind of hate them, right? Lots of what side effects? Sedation. Okay, so for all of these spasms medications, what side effects are pretty universal? CNS suppression. Wow, that's how they work, right? Lots of sedation. What populations are we probably not going to put them in? Our elderly population, alcohol. A lot of these also mention liver. Short duration, we can get a rash with soma as well. Because of the barbiturate, we can actually get dependence withdrawal, and we can get seizures with that withdrawal. Questions on our spasm agents? Sedating, CNS suppression.
Would you ever give Keppra or anything else to help, like, potentially reduce the risk of seizures while simultaneously giving one of these drugs that has an effect?
Good question. So question being, would we ever use anti-seizure medications to mitigate the risks of medications that could cause seizures? So typically not. The rationale is because we call what that is called a prescribing cascade. Meaning you do one thing, and because of a side effect, you do something else. Because of that side effect, you do something else. And so ideally, we want to choose a product that is best, that doesn't have future complications from it. Okay. Right? Someone's on a CNS suppression. Oh, it really helps their muscles. We'll just give them some Adderall. Right? That'll make them excited in the daytime. Right? And we do that. Right? Oh, but now they're too, now we need to give them Zolpidem or Ambien to help them sleep at night.
Oh,
Oh, now they're too sedated again, so now we need to do something else. So a lot of these things are happening, right? In the palliative care lanes, right, my position is split between pain management and palliative care. We do things like that intentionally because some products are going to be much better for a certain condition. Now we will do a prescribing cascade. But usually we want to avoid them. Okay. I also argued that for these products specifically that we're talking about, the efficacy isn't life-changing. Okay? From at least the data that I'm read. Okay? So again, this last one, Soma, we're going to have a GABA A agonist. It's barbiturate-like. Specifically, it's indicated in our spasms. But now we can switch over to spasticity with our benzos, which are also going to be GABA A's. The benefit with benzos is that these have a ton of different routes. Specifically with diazepam or Valium, it has many active metabolites. The oral half-life just of diazepam is over 40 hours. Its metabolites have half-lives of up to 100 plus hours. Okay? That can be good and bad. If you have chronic spasticity, you want something that's long-acting. You don't want something that only works for 2 hours and then you're at risk for having a seizure and you have to take your dose before that happens, right? You want something that's long-acting. Downside, you don't want to have something that's more CNS suppressive. The main patient populations that we've seen and treated in that are using diazepam are people that have stiff person syndrome. So it's just a spasticity pathway within their muscles. And they're well maintained on benzodiazepine. Because these are benzos, because they are controlled, we do have risk for dependence and withdrawal. Certainly with that, we have risk for seizures, black box or box warnings. Anything with other CNS suppressants, anything that could make it worse, and then making sure that we don't stop it abruptly and that we taper them off slowly. Benefit, because we do have such a long half-life, we have less of that risk specifically with diazepam. Baclofen, can't get my parentheses right on this one here, but these are going to be a GABA B. Okay, what were our other ones? GABA A. Unfortunately, benzos, barbiturates, and baclofen all start with a B. So you need to come up with another mnemonic to figure out which of those three are going to be your GABA B. Okay? The other two are GABA A. These are going to inhibit that GABA B, inhibit that excitability, so then we're having that decrease in function. Okay? This is oral and intrathecal, so we can get baclofen into these pumps. Okay? If someone has MS and they have a spasticity issue, we can implant this in them, and they can get baclofen infused in here to minimize the amount of spasticity that they're having. They don't have to rely on taking oral medications for that concern. We do have some side effects that will improve after prolonged use, but we do have a risk for hepatotoxicity with baclofen. We have a box warning with baclofen for abrupt discontinuation. That could be hallucination, seizures, and death in withdrawal. That's mainly going to be concerning whenever we have it in a pump. Okay? Patient comes in, they have a pump, we don't know what's wrong with them. Our first question needs to be, is it baclofen? If it's baclofen, that could kill them. Anything else that's in our pumps, we can manage. Okay? Without baclofen, for these patients, they can withdraw and they can die from it. That being said, I think we maybe have a patient that we don't actually own, but comes to the clinic every once in a while to get their pump filled. Xanadine. So again, all of our things for spasticity have unique mechanisms. Each of them are different side effects. Spasticity for tizanidine or Xanaflex, these are going to be our alpha-2 agonists. Some other medications that are alpha-2, you think of clonidine, fluoxetine, and dexmedetomidine. We have renal and hepatic concerns with this one. We do get hepatotoxicity as well. We're going to have different things like some of our CNS pieces as well. Because of hypotension, making sure that we're counseling patients so they could get a rebound if they stopped taking it. Okay. If someone has a little hint of high blood pressure and they also have spasticity, this is where I prefer tizanidine. Okay. We're actually treating two things with one. So trying to minimize that prescribing cascade, trying to minimize the amount of meds that we're giving them. Two birds, one stone with this one. All right, dantrolene. Dantrolene for spasticity. Test. Testing. Maybe. Yeah, that's okay. I can't hear speakers and talk at the same time. I already can't pronounce things, right? This is a lot to ask of me today. All right, do I need to go back at all? Okay, we'll refresh at a later date if we need to. Okay. So dantrolene is going to be one that has direct peripheral action. We're acting on the muscles themselves. We can have either oral or IV. Oral is going to be for spasticity concerns. IV is going to be reserved for malignant hyperthermia. What is malignant hyperthermia? A rare life-threatening muscle fiber breakdown due to different types of things that can happen when they're getting anesthesia. Okay, so we would only see this in the OR usually. Anesthesiologists are going to be your key people who know how to manage this. One of our docs, he's been an anesthesiologist for probably 10 years now. He's seen it twice. So not something that happens, but when it does, we need to make sure that we're reversing it and managing it appropriately. It is thought to be a genetic concern. Okay. Side effects, this is another big one. It actually has a box warning for hepatotoxicity and chronic use. So do you think this is one that we're going to use regularly for spasticity? Probably not. Okay, why not liver? All right, Botox is also a muscle relaxant. So these have direct peripheral actions as well. We can use these things for migraines, different limb spasticity, dystonias, if they have contractions or twitches of their eyes. This is an IM injection, right? Don't think too hard on that. It's going into the muscle. We dose this every 3 months. There are box warnings for migration, meaning you get Botox injected and it moves to another muscle that we don't want to be paralyzed. Okay? If it goes to something that shouldn't be paralyzed, that's not good. That can be fatal. Summarizing all of the hepatotoxicity concerns, since that was the thing that kind of came up, there's little evidence and support for all these other guys. Okay, the things that have rare and significant cases are tizanidine and baclofen. The ones that are clearly linked to acute liver injury and death are these other two guys. There is a suggestion that we should be monitoring folks that are on muscle relaxant therapy for their liver function at baseline and monthly in chronic use settings, and then whenever hepatic injury is suspected. Okay. Roughly 5% of folks that take these agents do have just a transient increase in their liver function, in their enzymes, but actual injury can still occur. So we have Alice. I believe when the slides were sent out, she was taking double the amount of Xanax. So Alice is our 32-year-old. She has intermittent acute muscle spasms during her fibromyalgia flares. It occurs every 2 to 3 months, and it lasts for 1 to 2 days. She's on alprazolam, buspirone, duloxetine, and pregabalin. Is she an appropriate candidate to receive muscle relaxant therapy? Seeing a lot of no's. Why?
The duloxetine is already.
Okay. So she's already on some CNS depressive things. You're just going to say, sorry, Alice, suck it up. Consult pain management, right? Someone else's problem, right? That's what we know and love, right? Who to consult? Are her spasms frequent? Are they happening all the time? No. Is there a known cause or trigger for it? Not necessarily. Is it tied to something that's already diagnosed? Yeah, for fibro. Okay, so fibro is a condition that comes in kind of waves, it ebbs and flows. During some of those waves, we see a lot more of these kind of spasms that peak through. As long as the duration is short, we can consider using many of our muscle relaxants for spasms. While there are risks, such as CNS depression, right, with some of these other agents, we could still consider and be nice to Miss Alice and find something that's not going to be too interacting with these other medications. So weighing that risk and benefit. You know what? You're on this alprazolam. tell me when you use it. I only use it once a week. It's always when I have to go and present in front of the PAs. That's the only time I use it, right? Hopefully not. Okay, that's fine, Alex. Great. When are these flares happening? I don't know, but I'd only want to take something on the weekends. I'm really busy during the week. Okay, cool. I think we can work something out. Because you're not taking your benzo on a scheduled basis, because you're doing these other things, right? Work with the patient, okay? So if this is your case and I say that she's on alprazolam, but she uses it once a year when she goes to the dentist, would that change your viewpoint? Probably, okay? So don't be afraid to talk to your patient before just hitting refer to pain management, okay? If that's the only thing that's hindering you. Okay, what about Sarah? 56-year-old, she has muscle spasticity throughout her scalp, neck, and shoulders, and it worsens her migraines. She struggles to remember to take medication and dislikes feeling groggy. Botox. Okay, so does she have an indication for Botox? Migraines, specifically, she's having spasticity, right? Muscle spasticity, Botox is an appropriate agent for. Okay? It's a local thing. She doesn't have to take anything for it. She doesn't need the CNS effects. All right, Mr. Russ, 79-year-old male. He's previously had a stroke, and he has ongoing spasticity that limits his mobility and activities of daily living. We see his vitals there, and we're on a handful of other medications for cardiovascular, mood, and diabetes support. Spasms or spasticity? Spasticity, wow, it's given in the case. It's almost like the exam will tell you that too, okay? So we have spasticity. So if you get a list of 5 and 2 of them are for spasms, cross them out. If one's an NSAID, cross it out, right? We're gonna be thinking, right? Using big brain stuff, okay? Cross out things that you know not to be true. Then it's gonna be case related, okay? If he's on these different things, what would make him a good candidate or a bad candidate based on the remaining answers? Okay? If the option is a benzo or Botox, right? That's a horrible 2 options as I presented, right? So the concern is that likely this is not a local thing. So Botox, probably not a good option. Dantrolene. Dantrolene's for spasticity. Wrist, super easy, right? Dantrolene, we have hepatotoxicity that is potentially fatal. We're not going to use that. We don't want Russ to have to go through that more than me, okay? We like Russ. Diazepam. Probably not. So our benzo, right? We're at risk of falling. He's elderly. Tizanidine. So tizanidine, what side effect do we have? What other mechanistically, what can it also cause?
Can you do your,
Please, yes.
thank you.
We need like a symbol. Right? Air traffic controlling. Okay, thank you. So tizanidine, what side effect do we have? Hepatotoxicity, what else? Hypotension. Okay. So that could potentially either be good or bad for Russ, depending on what's going on with them. Okay. Blood pressures, are they a little high, a little soft? Kind of high. Okay. So maybe it could help. You also don't want him falling at home though, because he gets ortho. Goes to the bathroom at 2 a.m. falls. That's not going to be good for Russ. Okay. What about baclofen? So baclofen, so long as he doesn't forget it. So again, that's primarily going to be more concerning if it's in the pump. now starting to hear it.
Renal dosing.
Okay, renal dosing. So of all of our choices, baclofen maybe, tizanidine maybe, right? Do you think that on the exam those are going to be the two options that I give you of the 5 that could be for spasms? Or
Hope not.
spasticity?
Hope not.
Hope not, right? I don't want gray area on the exam. Alright, we're just going to try to. Alright, these. B, nope. Is the class next door, does their mic connect? Switch mics?
That's not that
Too hard.
Pass over. Medco.
Class is over, you guys get another day. That's not gonna be fun. I know you guys have hard exams next week. Alright, for neuromuscular blockade. When we're thinking about paralysis, right, acetylcholine blockade, we're always going to start with our smallest muscles first that are going to be paralyzed, and they're going to move upwards. So face and eyes, fingers, limbs, neck, all the way up to the diaphragm, and then it's going to reverse in that same pattern. Neuromuscular blockade gives no analgesic or sedative benefit. Okay? If you paralyze someone, you're not treating their pain, you're not treating anything else. You're not sedating them. They're fully awake, being paralyzed. We can give it IM, primarily we're going to give it IV. There's different types of agents, whether they're depolarizing or non-depolarizing. The duration is going to depend on those things. Right? The two extremes are going to be our ultra short acting or our ultra long acting. So one in each of those categories. We're going to wrap up with these here in a few more slides. We'll do a quick break transition just so I can work on this mic a little bit more here. Okay. So in 2017, this is a real case. There was an ICU nurse that administered Versed. All right, we can go back a slide. Administered Versed. This was at Vanderbilt, which is a benzo for an osteolysis for a scheduled PET scan. Okay, so similar to like an MRI or a CT scan. Instead, she retrieved and administered to the patient vecuronium. So Versed is a benzo. What's the patient going to look like if you give a patient a benzo? Sedated. Are they going to be moving? No. Okay, they're going to be sedated. Are they going to respond to your questions? Probably not. If you paralyze a patient, are they going to be moving?
No.
Are they going to respond to your questions?
No.
No. So what happens to this patient?
Die.
Dies. Her diaphragm becomes paralyzed. She cannot breathe. On the outside, you don't know any different. Oh, she looks so calm. Okay? This is a true case. Okay? So at their facility, they were allowed to override it in the ICU. For that, there were many, many, many issues that were bypassed for this, unfortunately. Okay, the hope is that the patient lost consciousness before dying. Okay. In summary, we have all of our muscle relaxants. They're all going to have some sedation, some dizziness. They're going to be at risk of falling. Caution with the elderly, ensuring that they're short-term use. We have our agents for spasms or agents for spasticity, and then some quick notes on each of them. Remembering that there is no one size fits all, right? I can't just say, oh, always pick cyclobenzaprine, okay? Not going to be the case. It's always going to be patient specific. Skeletal muscles are going to be classified based on the primary indication and mechanism, right? Are they spasms or spasticity? And then what is that mechanism? Thorough assessment and risk factors of side effects need to be considered. And if an agent is ineffective, consider either changing that dose or rotating to a different agent. Okay? We're going to take a 5-minute break, 10-minute break, 5? 5 or 10. 10-minute break. Come back, we're going to wrap up part 2, and then we're going to start on part 3.
You like it?
I don't like this one. It tastes like feet. I like the big guys.
It gives me diarrhea.
I like the berries.
How's your mom? I don't think it's the battery. It's actually perfect to have a 3 day. Yeah. It's presidency. Yeah, it's a 3 day. So I think it's either we get the Friday off or the Monday off. We get the Friday off. Yeah, the Monday off.
Valentine's Day on Monday or
Saturday. Saturday. If you make reservations now, you should still have reservations. There's a test on Tuesday. What are you doing? Yeah, I've seen it. There's a restaurant
your husband
not this year.
I mean, the placement of the stuff is different. Unless you get the eye jacket. I didn't notice on the eye jacket.
Last week was the 100.
That's the bottom strap that like tightens shut. It's going that way from the middle, that way. I didn't know that.
Exactly.
Maybe eat an entire party pizza.
Wednesday night.
So what you gotta do is you have to go to
What are you doing?
they take
I like to be informed. That's pretty be here. And plus, we've done too many things on that time. I've never been that good yet.
Oh, stop.
More expensive, too many people.
That's true, but you can find it after the time.
Or just do the day before or after when it's cheaper and it's not. Because it's just a day.
It's not made up. It's my way.
So there's something like yeah, you go to HEB and they're all like half off. Like, fuck you, let's go. Same thing with Halloween. You know, like half off candles.
In Germany, a nursing home, they found the soldiers.
When I was here, I used to celebrate with my friends.
So I said, I'm like, all the way to the opposite side of the neighborhood market. And then she got her things there. And
Download the next one. Yeah. Oh, shit. Still got others.
That's fine.
You get $2,000 jewelry, and I get like a moment of this such great, like life.
Haven't watched those videos on social media where they just turn around and start looking at like this big box and just have one thing. Credit card and you go buy whatever.
Don't say that.
It's like petty stuff. Loud. Not loud. Not loud. Trip, I'm all about it. Like,
and you get the gold card.
So my question is, we talking all the things you like. You need to be about. I'd be giving divorce papers for that. Let's make it okay. Look, I get yelled at, you're like, I mean, 15 years.
Oh, wait, okay, so I asked you
I can't believe it.
That's like going out on
At that point, no, you're having a party. You're having a party. I'm not going in.
I'd rather do it
This is gonna be
You
huge.
used to? I'm not driving.
Yeah.
That was even worse.
And that second one.
For you? Watch England and Croatia's match. $7.50. Damn! Yeah, no, it's only cheap. I knew this. It's like lottery. You want to submit your name and they just draw names and then you can buy tickets and you can get
Starting at like 5.
There are matches in Seattle and then in Dallas, Mexico. Canada. But like they play England fans because they're one, but I don't know if it's gonna get selected. Yeah, you have to win the lottery.
So you win the lottery 2 days.
And that $7.50 is still kind of sitting if you want the full seat, it's like $3,000, like say $1,000. Higher the match is, like quarterfinals, semifinals, it's like price.
You know, there's so much better than that.
They won, They're like big. They get really bloody.
This one and two more. I don't know why.
What are you doing,
When I go back and read it, way too much. I don't know.
Make sure you call your squad.
Come to that game. I think
There you go.
I like
Oh,
it.
what time? Oh,
Yeah,
man.
we're gonna do something on Sunday. 'Cause she wants to.
Okay, that's what we're doing. We're doing something.
I've done too many.
This Valentine's Day is like just too much
They
going
always
on the
overcharge.
streets.
Like most restaurants either overcharge or have it like probably going to like go to the show.
What's that?
So like it would taste rice. All you can eat when you just come around and bring the variety.
Like, what's that called? Thanks to Brazil, that's what I was trying to say.
Same thing, but like
Is it cheaper or more expensive? But it's all you can eat, right?
yeah, they have a chill like cold bar where you get one of those like cold cuts.
So we're gonna go for another 30 minutes, but that means we'll be able to cancel an entire one next week. Hang in there.
Okay, so we just talked about muscle relaxants. They're going to be divided whether they're for spasms or spasticity, right, is a big piece of that. Things for spasms, when we're having peripheral actions, right, a little switch that's going on, those things are going to be CNS depressants. When we're treating spasticity, I feel like it's still going in and out. No? Seeing a couple head shaking. We're still good? Okay, okay. All right. Holler if it is. For spasticity, we have all these different mechanisms, right? One's alpha, one's GABA, one's another type of GABA, okay? Out of all of our muscle relaxants, which one can go into a pump? Baclofen. What's the concern with it? Death if we withdraw, okay? So we need to always make sure that our pumps are full with baclofen. All right, we're going to move on to some of our other agents. So our NMDA receptor antagonists. Think about very part 1. We talked about some of these mechanisms, right? We can block that NMDA on that postsynaptic neuron and go from there. We see things that we use in other disease states that also have NMDA receptor antagonistic properties. So things like Namenda that traditionally we use for Alzheimer's disease. We can use that in pain to help blunt that pain signaling from happening. Ketamine, right? You guys have talked about ketamine already. Ketamine is going to be an NMDA receptor antagonist. Methadone is one of our opioids that we'll talk about. That is mainly a good benefit with methadone is because it also has this NMDA receptor antagonist property. Suzetrazine or Jornavax, noticing the color highlights. So it's a sodium V1.8 receptor blocker. Okay, so that's that X. It's going to be where these sodium channels are is within the periphery sensory neurons. Okay, and that's going to help inhibit the pain signal. This is going to be for moderate to severe acute pain, usually in the post-operative setting. I believe University, for dang near any single one of their procedures now, they are giving their patients Jornavax. Okay? This is a medication that was just fast-tracked approved by the FDA in January of last year. The FDA is on this big kick saying that we don't want any opioids. Opioids are bad. I feel like it's a little, 10 years late to the game for this, but better late than never maybe. But they're fast-tracking a lot of these medications. Okay, Jornavax is the only one that has actually been approved for this specific mechanism. All the other manufacturers that have made products for this mechanism have discontinued making their products. So in their research trials, they're finding things that aren't that great. Okay. How we dose this for that 2-week period is we do an initial load, and then we gradually reduce that dose and maintain it for that 2 weeks. Jornavax itself, or suzetrazine, is going to be a 3A4 substrate, meaning it goes through and relies on 3A4. It is also an inducer of 3A4 metabolism for other medications. It does have a fun named active metabolite as well. Another thing that we can put into these pumps is called ziconotide or Prialt. is a very large chemical structure, and it is made from the venom of the cone snail. So if we inject a little bit of venom into you, it's going to change those action potentials. Okay, so a very unique mechanism. A big side effect that we see with this one is confusion and cognitive impairment. The benefit is that it is reversible. We change that dose, we change how fast it's going, and everything clears up. Our docs like using this for our severe chronic pain patients, like considering it. The downside is typically folks that have severe chronic pain are our elderly population. Our docs don't like getting pointed at, saying, oh, you caused this person's confusion. And our docs usually say, you sure you didn't check if they have a UTI? And that's why they're confused, right? So again, the big side effects, that confusion, is going to be that limiting factor as to why we might not consider ziconotide, because the patient populations that are going to have severe chronic pain are going to be those that are more at risk for that confusion profile. Wrapping up part 2 here, remember that part 1 and part 2, we have many non-opioids and adjuncts that are available for a variety of different pain conditions, making sure that we're selecting things based on patient factors, understanding what the mechanism is, the routes, the uses, the dosing, pharmacokinetic pieces, as well as side effects. Knowing that effective pain control may require using a variety of different treatments. Okay? If they have low back pain and radiculopathy, do they have axial and neuropathic? And so do we choose one agent that could work on both? Nociceptive and neuropathic, do we choose 2? What other conditions is this person having and experiencing? Where in the pain cycle is this working? Okay? Thinking that excessive dosing or otherwise could accelerate, could cause some accumulation, and making sure that we manage them appropriately. So what toxicities did we talk about? Where we would need to reverse it? Aspirin, Tylenol. Okay, so those are our big ones. Which one could kill you? Baclofen withdrawal. And then thinking of some of our other hepatotoxicities, right? Our high fatal risk of hepatotoxicity among some of our skeletal muscle relaxants. Again, there's tons of different resources for you guys. We're going to transition over and start with part 3 with our opioids. We're going to skip ahead a few slides. We'll come back to this memory jog next week when we start class. So we're now on part 3 of our opioid lecture, slide 231-ish. Just start talking about our opioids. So first part, we're going to go through different mechanisms, uses, and treatment approaches when we're picking opioid therapy. How opioids work is they're going to activate that descending pain pathway modulation. We're going from the brain back down, and we're saying, hey guys, stop talking, stop sending the signal back up, right? Where that's descending pain pathway. We're interfering in that spinal cord. We're inhibiting that transmission that's going. We're altering then the perception. We naturally have opioids in our body. We have endogenous opioids that when I touch the stove and I take my hand off, my body's going to say, yep, I need to keep giving you some opioids because this hurts, right? So we naturally have endogenous peptides that work within our body to give some natural pain benefit. The downside with that is when we start taking external opioid therapy, our body no longer has a need to make its own. If we supplement with some pill, our body doesn't have to make these natural opioids anymore. So the second we take this pill away, we no longer have a natural coping mechanism. We feel horrible. So part of that is going to tie into the stigmatizing nature that we think of with opioids. Right? There's an actual mechanism behind it. This person previously was making these natural things to help cope. They previously were making this, their body got used to it and didn't have to make it anymore. Your body was smart. When we take it away, your body needs time to regenerate those natural opioids. When we activate these different opioid receptors, we're going to get changes to our pain, benefit to our pain. We're going to notice some sedation. We're going to have respiratory depression. We're going to have euphoria. And we're going to have dependence. And we activate all those things. When we pick specific opioid receptors, there's three main ones that we'll chat about. There's other mechanisms and concerns that can happen at those. So when we activate our mu receptors, we can get a constriction of our pupils. We can get really bad constipation because we reduce our GI motility. Okay, that peristalsis is no longer going. We can also get histamine responses when we activate that mu receptor. Delta, we'll hear about, we don't really know what delta does. Okay? Kappa, when we activate kappa, we get dysphoria. So now the question is, going back to Pharm 101, what's the difference between agonist, partial agonist, antagonist, inverse agonist, and now I get to do more flight attendant stuff here. Okay? So an agonist, I think, well, all of these things. I think of like a saloon door, right? You can go in it, you can go out it, it's double hinged, okay? An agonist is going to fully open both doors. You get peak effects, everything's happening with an agonist. We activate the receptor, there's no ceiling. You open both those doors, everyone can come in. Okay, stampede. Increasing dosing will increase all the risks for overdose. Examples of things that are agonists and which receptor they're at. Morphine is a full agonist at the mu receptor, as is oxycodone and fentanyl and methadone. They fully open those doors. Partial agonist is only when one door is open. Okay? We're going to be a little bit more selective. We're still going to let some people come in. We're going to feel okay, but the bar is not going to be too crazy or anything. So the benefit is now we're modulating. We have some kind of ceiling effects that can happen. Not everyone and their grandma's coming in, just some of them. We're getting some of that benefit. So we have the ceiling effect. An example that works here, buprenorphine, is a partial agonist at our mu receptor. We have antagonists. So remember that antagonists just sit on the receptor. We're just putting a lock on the door. We're not activating, we're not unactivating, we're just sitting there. We're just occupying that space. Nothing else can do any action here. We're just sitting here. Naloxone and naltrexone are examples that do this at all different types of opioid receptors, whether it be mu, delta, kappa. An inverse agonist is that stampede is going the other way. Now we're leaving the bar. Okay? We're having the opposite action at that receptor. So buprenorphine at kappa has inverse agonist properties. So going back a slide, what happens when we agonize kappa? Dysphoria. Now we're going to do the opposite of that. Is that going to be a good thing? Yeah, potentially a good thing, right? We're not going to have so much of that CNS effects with it. Okay, so looking at this list, the majority of our traditional opioids are going to be agonists. Buprenorphine is the one that falls into this odd category where we kind of let some of these things in at mu, and we don't let the CNS thing happen, and we're doing the opposite effects at kappa. So buprenorphine is a good middle ground when we're trying to pick something for opioid use. The different types of things how we can use opioids. So we have tons of different formulations. We have immediate release. We have long-acting products. Knowing that long-acting products should only be considered when someone is tolerant to opioids. Nicole does not take opioids. Nicole should not get a long-acting formulation of an opioid today. Okay? My patient has been on oxycodone for 6 months. Their body can tolerate being on opioid therapy. They can be on a long-acting. Okay? Typically, that time frame when you consider them being able to be on a long-acting is 1 week of continuous use. So it's not that they took an oxy on Monday and then another one on Thursday, and here they are at clinic. Every single day, they took an oxy every 6 hours around the clock. Okay, their body is now used to that. They can get something that's longer acting. We have non-pain indications that we can use opioids for. So if someone has trouble breathing, if they have a cough, we can use it, right? When we activate mu, we can actually get some of that respiratory depression. So we can use it in patients that are having a respiratory increase. We can just tell the brain, stop worrying about it, right? Reduce that respiratory drag, it's fine. We do that in palliative care all the time. We can also use it for diarrhea, okay? Loperamide we use for diarrhea. Guess what its mechanism is? It's an opioid. It's an over-the-counter opioid. Okay, so opioids, when activated, are going to reduce at mu that peristalsis. So if someone has diarrhea, we're going to go ahead and we could use an opioid for that. And then in some instances for opioid dependence or opioid use disorder, we can use it as well. For pain, we're going to use it for all different types of pain conditions. Ideally, we're going to limit it to severe acute pain. So if someone has a procedure done, they have an injury, and we're anticipating that they're going to have severe acute pain, then we can use an opioid. If someone has cancer-related pain, we can use it as well. If someone's either receiving the support of palliative care or end of life, opioids may be appropriate. And then again, it's still controversial, but we may consider it in severe refractory chronic pain. You've tried everything, you've done your best shot, maybe we do need to consider opioids. However, right, I mentioned the FDA is really getting into this stuff. So in August of this past year, they came out with a statement saying that chronic long-term opioid therapy, or LOT, has not demonstrated functional benefit, continues to exhibit serious risks and complications. The FDA is doing all this different research. So this is a snippet from their statements, but the limitation is that in pain management, in chronic pain management, we care about functional improvement. I don't care that your pain went from an 8 to a 7. I care that before you couldn't walk your dog or get out of bed or do these things, and now you can. I'm giving you this oxycodone, and now you are functional. Okay? So chronic pain management, we really care about functionality. And the studies continuously show that chronic opioid therapy does not improve function. So given all the risks that we'll talk about, opioid therapy really is not encouraged and recommended in these populations. When thinking about opioid therapy, there's a couple different ways that we're going to dose patients. So we can do something called around-the-clock dosing, or a basal approach. Right? Think of many of our insulins are like this. So these are regularly around-the-clock dosing strategies, either an every 8 hour. It should be ideally reserved for our long-acting products. Okay, you're taking a long-acting oxycodone, taking that around the clock. That's your basal pain control. We also have as-needed or bolus pain, and so we can do different pain for our breakthrough strategies. And this would be reserved for our short-actings. So how I like to describe it and think of it conceptually is that we have an ocean with waves. So think of a patient who has, let's say, lung cancer. Okay, they have lung cancer, they have metastases to their spine, into their lungs, maybe they have some in their brain. Okay? They probably always have some pain. So I think of that as the ocean. They are always going to be at a 5 out of 10. for their cancer-related pain. That is what our basal dosing needs to cover. I'm always going to keep you covered for your ocean, for that chronic pain that you're having with this cancer. But every time you get up or you have to do something or this and that, you have known triggers, that's when these waves come in. These tidal waves are happening. Okay, they're short-lived, but they come, and when they hit hard. That's where our PRNs are coming in. So whenever we have an ocean for a patient, we also need to anticipate that they're going to have tidal waves. So patients that have a basal pain control with a long-acting formulation should also be supplemented with something to take as needed for tidal waves, a short-acting PRN. That patient comes in and they tell us how they've been taking it. You know, I'm taking my ocean dosing, I'm taking that basal dosing, and I'm taking about 2 tidal wave dosings, those PRNs a day. We take all of those doses, and that is considered our total daily dose. It's your long-actings, your short-actings, everything's added up together. Other things that we can consider doing are going to be a continuous dosing approach. So this would be some sort of infusion. Patches also would be a continuous dose. When we're doing infusions, this would be in hospital, we're going to have it in a lockbox at bedside. Okay, so they're going to have a fentanyl drip going continuously or a hydromorphone drip going continuously. Bedside, you'll see it in a lockbox. On top of that, so again, that's just treating that ocean. On top of that, we can then do what's called a PCA, or patient-controlled analgesia. So this is an infusion pump where there is a demand dose or a button that the patient can press. We determine what the dose is. Okay, so we say your ocean is here, your tidal wave we're expecting is going to be here. We're saying that when you press the button, this is how much you can get. So the patient doesn't get to pick that. They don't get to say it's 100 if you say it's 5. If you say it's 5. Okay, they just get to pick when they get it. You also get to say how often can they press the button. Okay, so your waves can't be any sooner than every 30 minutes. Okay, then your light will turn green, and then if you need it, you can press it. Okay. PCAs can also have that ocean on it, that basal rate. You would not use a PCA button if the patient doesn't have cognitive function, right? If they're sedated, we're not going to give them a button. They can't use it. The amount of times I see this is too often, okay? So don't give it if the family is pressing the button, if the nurse is coming in and pressing the button. The only person who should be pressing it is the patient. We should only be pressing the button when it's treating pain. So it shouldn't be treating their anxiety. I just press it because my mother-in-law is coming in. No, right? I know it's emotionally painful, but not today, okay? So we only need to be pressing it for pain. And again, those barriers. So do they have any cognitive concern? Do they have dexterity issues? And then do they have visual impairments? So all the things that we talked about are going to be tied back to the CDC. They have 12 specific guidelines that relate to opioid therapy. And so as we'll go through these slides, I'll relate them back to these treatment approaches. So number 1, determine if it's appropriate to initiate opioid therapy in acute pain, right? So we know we can use opioid therapy in acute pain, but is it appropriate for this patient, for this indication, for what's going on? They also encourage that non-opioids are preferred in both subacute and chronic pain. Okay. What is subacute? What's that duration? 4 weeks or 1 month to 3 months. Chronic pain is 3 months. Okay. So they're saying don't pick opioids unless it's less than 4 weeks. Okay. We want all the other things we talked about before we pick an opioid. If it's warranted, we're going to initiate a short-acting first rather than a long-acting. So if we have to pick an opioid, we're going to pick something that's short-acting. Again, we need to get that tolerance first. If we're going to start it, we're going to start it at its lowest dose, lowest effective dose. If it's acute pain, twisted my ankle, it's horrible, all these things are going on, and opioids are deemed appropriate, we need to make sure that we're only giving me enough for the duration that the pain is expected. Okay, if after a week I'm gonna be fine, don't give me a 3-month supply. And then making sure that we have regular follow-up whenever that therapy is either initiated or increased. So to summarize kind of opioid overview, opioids inhibit that transmission within that ascending pathway of our pain. We have additional mechanisms noted both centrally and throughout, right? GI and other things are going on that can have tolerability concerns. Opioid therapies may exhibit full, partial, or inverse agonism at these opioid receptors. Opioid therapy should be used selectively in appropriate populations, and they can come in many different formulations and be dosed in a variety of different ways. Questions on opioid overview? All right, I think we're going to pause here.